Good evening, everyone. Welcome to the Daily BALM. So good to see all of you here tonight and all of you out there who are watching this after a hard day or perhaps a hard week, knowing that you'll have something from the BALM that'll help you get through the day and understand what you and your family and your loved one are going through just that much better. We're very fortunate to have here tonight Dr. Vaughan Gilmore, and I'm going to put her bio up as I started to before, and I will read it and you will see it. Vaughan Gilmore, LCSW, LCDC, is the Director of Addiction Services at the Menninger Clinic, a nationally ranked leader in the treatment of serious mental illness. As the Director of Addiction Services, she leads a team of addiction professionals focused on providing integrated treatment for co-occurring psychiatric and addictive disorders. In her leadership role, Ms. Gilmore has integrated peer recovery services into the inpatient setting and helped to implement hospital-wide outcome measures focused on substance use disorders. Her professional interests include expanding access to recovery pathways and reducing stigma associated with addictive disorder. She provides presentations and training on a range of topics related to the assessment and treatment of substance use disorders to both mental health and medical professionals. A graduate of Texas Christian University, Ms. Gilmore obtained her master's degree in social work from the University of Texas at Arlington. And welcome, Vaughan. It's so good to see you.
Thanks for having me.
We're really pleased that you could come. Could you share with us what brought you to the field of addiction and recovery and where you get your passion for the field?
Sure. So by training, I am a social worker and sort of started in the field of social work early on, actually not really knowing what that might look like and where that journey might lead. After doing several different sort of training programs and internships and things like that, found myself doing what we used to call dual diagnosis, now we call co-occurring work actually with adolescents initially, and just really sort of felt at home doing that work. I think one of the things that attracts me to, substance use disorder work, addiction work, and also co-occurring work is, as devastating as it can be, recovery is also this sort of amazing thing to see as well, to really see people sort of move through it, to see individuals, families truly recover, because we know that recovery is possible. It's like such an amazing thing to witness and be a part of somebody's journey. And I think that's what sort of keeps me doing this work.
Wow, I couldn't agree more. There's nothing like seeing a family come in. It's awful to see them in total heartbreak, but to see how they navigate the journey, making a positive impact on their loved one and turning their own lives around. Really powerful. So your bio reads that your hospital is for the seriously mentally ill. Tell us more about how that's defined and what it means when there's also substance use disorder going on.
Sure. So we really specialize in what might be called like complex psychiatric disorders. So most of our patients have multiple psychiatric disorders. For about 70% of our patients, that includes a co-occurring substance use disorder or addictive behavior. But all of our patients are coming in with multiple diagnoses. Most of them have had several other previous treatment episodes, hospitalizations. They've been to residential, they've done detox, they've kind of tried multiple other attempts at whether it's recovery, treatment, et cetera. And then they sort of finally end up with us. And we do quite a bit of what's sort of like a diagnostic evaluation with a multidisciplinary team to really identify what we call core issues to kind of guide the treatment moving forward and have a better understanding of, why hasn't this person been successful for co-occurring disorders that often looks like people that have had repeated attempts at addiction treatment, but have not had high quality psychiatric treatment. And so when they come in, we're maybe able to say, well, we think the reason you haven't been successful is no one has diagnosed or treated your borderline personality disorder. And until we address that and understand that, that's really getting in the way of your success at sobriety and recovery. And so then when we look at how those two things are related, we're much more successful.
And when someone has complex mental health problems, how functional can they be in the world upon recovery?
Sure. I mean, I think that people can absolutely live meaningful, successful lives that are sort of true to their values and have healthy relationships regardless of their mental illness or their diagnosis. That really should not be a limiting factor.
Beautiful. What would you say is the most helpful piece of the puzzle? The medications that you figure out for them, the treatment care, the proper diagnosis? I mean, how? Because medication is so central to what's happening today in treatment centers. And
it's, there's not one formula, right? We say that recovery is not one size fits all. Treatment is not one size fits all either. So I think when you're looking for high quality treatment, you're looking for a multidisciplinary approach. So you do want an addiction psychiatrist on the team. You want a comprehensive psychiatric evaluation. Sometimes psychological testing really can help give clarity to what is going on. A strong psychosocial assessment. It's multidiscipline, social work, nursing, psychology, addiction professionals, recovery specialists, all of these people coming together to give clarity and guidance. And the most important member of that team is the patient or the client, right? They know themselves and the family as well. And so in terms of like, what's the secret formula, often it is us understanding and getting some clarity in terms of assessment to guide what's going forward. And I think sometimes when people start out in addiction treatment, addiction treatment centers take you or take your loved one and say, here's how people recover. Here's the formula, do this, this, and this, go to this many meetings, and then they'll be better and they'll stop using substances. But actually that's really way too quick. First, we need assessment. What's going on before we can even make those kinds of recommendations.
That's really interesting. You're known for your assessments at Menninger, and we're going to talk about that at the end, because really, this isn't about Menninger. It's about the substantive knowledge that you bring to bear from your work there and your whole career. But I do have a question about treatment. There's an old saying, nobody ever woke up and said, hey, great day to go to treatment. And yet there are lots and lots of people in treatment. How important, you talked about the importance of the person in the process. There are lots of people who go into treatment kicking and screaming. What are your thoughts about that? If somebody is kicking and screaming, do you take them, or do you only take people who want to be there? And how does someone with a complex mental illness, substance abuse disorder, even get it together enough before recovery to know what they want?
I will talk about this in thinking about actually the stages of change, which I imagine you guys probably talk about in your program.
Yes.
We have research like from our clinic, but many other clinics do research like this as well, that most people are in a pre-contemplation or contemplation stage of change when they come into treatment. And so the best treatment is matching intervention with stage of change, right? Which I imagine families are coached to do as well. But actually treatment centers should be doing this too. So you should be looking for a treatment center that also does this, where if somebody comes in and they're in a pre-contemplation stage of change and, okay, you've been here 24 hours and now you need to go to that relapse prevention group. Relapse prevention, I don't even know if I want to stop using drugs and alcohol. Why are you sending me to a relapse prevention group? So what we want to do first is target their motivation to change. Before we teach recovery maintenance skills, we have to actually target that. The same way family members might be sort of trying to contribute to motivation to change. That's really often the job of the treatment professionals early on when somebody gets to treatment, is moving them into a contemplation stage of change to start with.
So what I'm hearing you say is that it's important to individualize the treatment to each person and where they are.
And assessment often includes assessing what stage of change somebody is in so that we can work with them based on where they are. And sometimes that question is, what are you willing to change, right? You've been pressured by your job or by your family to be here. You've sort of agreed begrudgingly. And what would you like to get out of this? What are you willing to change? Well, I'm willing to stop drinking, but I'm not willing to stop smoking marijuana. Great. Let's talk about that. Let's work on the changes that you are interested in making while you're here.
It's interesting. So you're not an abstinence only, you don't have an abstinence only perspective.
We have an individualized perspective, and for clients that are only willing to pursue a harm reduction approach up front, we're going to work with them on what they're willing to do. Now, we're hopefully that's when they come in. We hope that after 2, 4, 6, 8 weeks with us, they've progressed and maybe they've said, you know what, I at least don't want to drink for 90 days. You guys have put me on medication. You know, I've learned a lot. I've realized that if I keep drinking, it makes my depression worse. I'm willing to not drink for a period of time. Or so we hope that actually over the course of treatment that changes. That's the goal. We don't expect people to come into treatment. Now, some people do, but we don't expect everybody to come into treatment. I have a problem and I am ready to stop using all drugs and alcohol and problematic behaviors for the rest of my life. That just doesn't happen.
Right. So when you think of the overlap between addiction and mental health, what does that bring to mind in terms of ideal treatment?
Sure. I mean, the overlap is huge. We have, tons of research on how these are related, whether it's, the sort of depression, anxiety, mood disorder leading to substance use, or it's substance use causing an onset of mood disorder, depression, anxiety, psychosis, right? It goes both ways, but we know that the best treatment is treating both at the same time. It's, in the past, we used to see people that was like, well, first let's treat the depression and then maybe they'll stop drinking and using. Or, well, if I could just stop using, then I wouldn't be depressed. But we actually know we have to treat them together, not sequentially, but integrated, where we have sort of both represented in the treatment.
Boy, that's so interesting. It reminds me of the BALM. In Al-Anon, which I love, I learned just take care of yourself and you will be that model. You will impact your family. The BALM is quite different. I don't know how much you know about it, but we are simultaneously teaching people how to help themselves and help their loved ones. Because if you don't integrate, you have to calm yourself. You really have to have self-care and all the good things that a person needs to feel good inside about their life. But at the same time, you have somebody in big trouble. So you need to learn simultaneously how to help them get well.
Absolutely.
Not contribute to their getting worse. And it sounds like it's that kind of an integrated approach that you're talking about for the individual.
For the individual, and part of that is the individual understanding how those things are related, right? When people are active in their addiction, or, really suffering with their symptoms, they really don't see what we might be able to see from the outside. Sometimes it can seem so obvious. Well, yeah, when you're using, you're irritable, you're not sleeping, but they may not have that insight when they're active in those problems. And so a lot of times, and that goes back to moving people in the stages of change, it's helping them understand how these things are related. That insight really can develop some discrepancy around the way they were perceiving things.
Right. So with all of that in mind, how do you help someone who's really using alcohol to ease their mental health symptoms or drugs?
I use alcohol a lot as an example because it's actually the number one substance we see, individuals misusing and having a problem with. It's certainly not the only one, but it's the one we see the most. Helping people understand that is a lot of motivational interviewing, where we are developing discrepancy. It often is an initial period of sobriety, which residential treatment or detox can be very helpful to give people that 30 days of clarity, right? It's like, oh, wow, I'm feeling so much better, right? We want people to be at the lowest level of care they can be, but for some people to get that initial period of time, it is a higher level of care like residential or detox, where they're able to gain some perspective. But that is often the task of the professional. Again, before we get to how does somebody sort of maintain their recovery, we have to get to wanting recovery. And that is often through developing that discrepancy and building some insight.
And for those who are new in the program, could you talk a little more about what it means to help a person develop discrepancy?
Yeah. This is a common sort of like motivational interviewing technique where we are really helping them see the difference between maybe what they want and value and think that's important to them and their behavior, right? So my family is often a top value for people: family, work, health, safety, right? These are things that people say that they value. So when you got them to talk about those values and even put pen to paper about those values, and then point out how does your behavior sort of interfere with that value, it can kind of turn some light bulbs on for people. And it often might be a lot of talking about that.
Yeah, very similar to coaching. When you're, I'm a recovery life coach, and that I worked with persons in recovery and struggling to find recovery before getting into work with families. And it's very similar. Just that developing discrepancy, what is it that you want for your life? When was the last time you experienced it? What was your use like then?
Yeah. I mean, because what happens for individuals who are suffering and for the families is these problems develop so slowly and they creep in, right? That we don't, just like you might not see how bad it's gotten till it's really bad. The same is true for the individual that's suffering too, right? Like they often don't see that either. Again, it can seem so obvious from the outside, but when you're in it, it's not.
Exactly. It's why it's so important to break through that denial. We say that denial is the glue of the use disordered system. It just keeps everything staying the same. And as the family members and loved one break out of that denial, hope arises. What do you do with families, manager?
So we have a lot of different programs. So we primarily, again, individualize it with actual family therapy with a licensed clinical social worker or professional counselor that is working directly with the family and the patient. So that may be true family therapy if somebody's in one of our longer community integration programs and we're doing weekly family therapy with whether it's sort of adult parents, spouses, adult children. And then for some of our other programs, especially our shorter programs, it's too soon for family therapy. right? Everybody is in crisis. The client is in crisis. The family is in crisis. They're exhausted. They've probably spent a lot of time and energy getting their loved one even into treatment at that point. So a lot of the social worker's job is just providing support to the family. That might be resources, just listening, coaching, education. It might be some like sort of educational or informational calls and meetings with the patient and the family, but we often are sort of sowing some seeds for family therapy, but that's a long process. Again, like we were saying, people didn't get into this situation overnight. And, 2 family sessions over a 4-week or 30-day stay at a treatment center is not going to resolve everything. We also really want the patient to be in the right sort of mental space, like, to be in the right place to even do family therapy, right? What groundwork do they need to do? And maybe the family needs to do before we can truly benefit from family therapy. So, we have family education day, we have a new family orientation, and then what type of family therapy or couples therapy is really varies depending on the situation.
Mm-hmm. Interesting. So this week in the BALM, we're talking about boundaries.
Mm-hmm.
How do you deal with the dichotomy between setting the boundary of abstinence and knowing that some will use again?
Sure. I mean, we have lots of statistics on, relapse rates, between 40 and 60%. In terms of substance use disorders, the frequency at which people relapse. Mm-hmm. So one of the things that we like to do with our patients is not only developing like a recovery management plan, but part of that recovery management plan is a plan for how to manage a relapse. And that can feel a little bit uncomfortable for some people, like permission, which it's really not. We know that again, the reality is a large number of people will relapse. Most people need more than one treatment episode or attempt at sobriety before they get it right. So what we want to do in terms of like setting that boundary, the expectation is sobriety or recovery, if that's the goal that they're committing to. And how do I get back to that as quickly as possible if I do have a relapse? So we use there's a couple of, if anybody's familiar with like DBT, dialectical behavioral therapy, there are actually a couple of DBT SUD skills, and one is called dialectical abstinence. So this is sort of something you can look up and may be of interest, but part of dialectical abstinence is planning for abstinence and recovery and planning for managing a relapse at the same time. It's sort of the combination of sobriety and harm reduction. So I think when we're thinking about boundaries and limits, even for our clients in our community integration programs or our recovery management program, it's an abstinence-based program. And we're not going to kick you out if you have a relapse, right? We're going to work with you. Do you even consider that a relapse? I know that might be also controversial, but how are they framing that, right? If they've had a recurrence of use, how do we get back to your goal as quickly as possible so that you're not sitting in shame, so that you don't isolate more, so that you don't really kind of have to start all the way back over. We actually just want to meet people where they are and get them back to their goals as quickly as we can.
One of the things that we recommend that families find for their loved ones and our recovery coaches use with their client, with their designated clients, are WRAPs, Wellness Recovery Action Plans. How do those differ, or are they the same as your recovery management plan?
It's similar. We use a couple of different things in our programs. We have a wellness plan that we do or offer for every client and patient to do. And then we have a recovery management plan that's a little bit more specific to substance use. But it is similar to a wrap. Yes.
It's interesting. Yeah, I know that wraps were originally created for mental health challenges, and yet they really go well with persons with addiction and with co-occurring disorders.
And I think, I know this is a lot for families when you're looking at prospective programs, when you're looking at, like really what's the best fit. Historically, it has been the practice in the industry to like one violation and you're out, right? One use event and that's it. You're out of the house, especially with sober living. This is a very common practice that I find really kind of backwards and against the research, right? Oh, you've just had a relapse and you're in crisis and we're kicking you out of the house and you are on your own. Don't go for those houses. Those are terrible.
It's funny. I remember my husband used to run a teen treatment center, and a counselor would come in and say, Alan, he is bad. He is misbehaving. He's about to relapse, just on and on. He said, 20 days ago, he came in totally wiped out. And you're expecting perfection today?
So, so thinking about like really the best practice and where I think that the field is moving, right, is we can be abstinence-based and still work with people when they have a use event, right? That's, I think, where we are hopefully moving as a field.
Yes.
I think that families, in terms of setting boundaries and limits with your loved one, can take a similar approach, that the expectation is sobriety as abstinence, and you can kind of put your parameters there that you're able to stick to with that, and have a plan for what you want your loved one to do if they find themselves moving into relapse or they have had a use event. How do you want them to come to you? Like, and actually, again, thinking about it like with a teenager, right? Creating that permission that you can come to me if you're struggling with that. We see a lot of family members that are like, what do you mean you're thinking about using? Well, of course they're thinking about using. Addiction is a brain disease. Of course they're craving. Of course they're triggered. So we often have our patients share their recovery management plan with their family, so that they know, including, this is my plan if I do have a use event, so that we can work through it together.
That's fabulous. That is really, really very good. So when families are looking for a treatment center, do you recommend that be one of the questions they ask? How do you handle use events? Same for sober living. How do you handle use events?
I think so. I mean, it's less common in a residential setting because, it happens, right? It happens everywhere that people will use, right? It's less common, but in sober living, that's really quite a common, historically has been a common practice. I'm seeing it sort of start to shift, but yes, I think that's a great question to ask a house. Or how will you, again, my family members in crisis, they've just used, how will you surround them and support them? And maybe they do need to move up to a higher level of care at that point, right? I think it comes down to how will they approach that? Yeah.
Right. There's a balancing act. I know of a good recovery residence in Florida where if someone drinks or otherwise uses, they need to leave for 48 hours and then they can come back.
Yeah.
And I remember thinking, but what are they doing in those 48 hours? Where are they going? How are they safe? So the recovery residence has to balance the safety of everyone and the safety of that one person. What would you recommend in that?
Absolutely. I mean, that's the same as with a family, right? That may be your line, right? You do have to leave for 48 hours, or here is the limit. But that's part of coming up with that relapse management plan, where will they go for that 48 hours, right? Is there another family member's house that they can go stay at briefly? Do they have to, if somebody has a single use event, they don't need to go all the way back to detox, right? In that type of sober living setting or recovery residence, maybe they have, again, if it's sort of a really great place, they've got a plan set up where people can go, because they are balancing the safety of the community, right, with that individual. And so I think that's where some of that practice comes from, is the safety of the house and not disturbing everybody else. But that's the same as in families, right? That we do have to balance the priority of the well-being of our whole family with what the loved one needs.
And it just reminds me about the need for greater investment in persons facing use disorders, because ideally there could be a respite, there could be a place to go. You need to leave here, but you can go here, take a day or two and come back. But there just hasn't been that kind of investment. I know there's a $41 billion proposal on the table right now.
I know.
But will we get it? It's another question. So Menninger has such a stellar reputation, and yet it's really not something that most families can afford. So could you talk about the work that your clinic is doing to get your level of research and treatment out there into the broader community?
Sure. So we are a training hospital. So we have all kinds of trainees within all of our disciplines, like, nursing, psychology, psychiatry, social work, counseling. We have training programs. So often you'll find Menninger trained clinicians at all kinds of programs around the country. They come and do a fellowship or a residency, and then they go off into the world. So there's great sort of Menninger training happening through our programs. And then also our research is, really probably one of our biggest contributions in terms of really conducting research in a wide range of research, outcomes data. We've got, outcomes data in terms of substance use disorder outcomes, but also things like well-being. We're researching sleep. They're doing like fMRIs. All of this research is sort of contributing to the literature to try to sort of disseminate sort of this high quality level of care to lots of different people. One of the other things we have is multiple levels of care. And, when we're talking about like what's people's sort of approach, sometimes looking for a program that has many levels of care can be useful, so that your family member can move up and down that continuum, right? So our outpatient therapy, IOP, PHP, community integration, inpatient, detox, right? All of these different levels of care, so that we can meet people where they are. And if they need to move up briefly and then come back down, they also have that as an option.
So when we talk, you talked earlier about harm reduction, about integration. How do those two things go together in a treatment facility?
The harm reduction and
reduction and integration of treatment.
Yeah. Sure. So I think sometimes what harm reduction looks like when we're treating a more primarily psychiatric population, maybe people that have problematic or misuse of substances, but don't have a dependence or an addiction. That's very common, where we might see somebody coming in with depression or anxiety or trauma. And well, no, you don't have an addiction, but we're also recommending that you stop using substances, right? The marijuana that you're using to manage your anxiety is actually making things worse, right? Or the alcohol that you're drinking to be able to fall asleep at night is actually making your sleep problems worse. So, the idea is to intervene regardless of the level of severity. Again, why assessment is so appropriate, right? Not everybody that has a problem with substances or has misused substances has an addiction. And so we want to work with people based on kind of where they are and what's actually going on. And so that might be recommending a period of sobriety or a period of abstinence. I think that anybody coming through our hospital, and I say this to patients all the time, is if your psychiatric symptoms are so bad that you're in an inpatient hospital, my recommendation is that you're not drinking for 12 to 18 months, regardless of whether or not you have an alcohol use disorder, because of how much it can complicate things.
And what kind of reactions do you get? Because people who don't have a problem can still have a heck of a difficult time letting go.
Yes. I think the way I would answer that is I think how resistant somebody is to letting go is information about how big of a problem or how meaningful it might be for them. Because if I went to the doctor and they said, look, the headaches that you're having, it's because you're eating apples and you just need to stop eating apples. I love apples, but I would stop eating apples if it meant I would stop having headaches.
Absolutely.
So I think people's willingness, right, when we say your sleep is going to be better, your mood is going to be better if you stop this behavior, and they say, oh, great, that's easy, right?
And I guess that's one of the ways that you find out if they do have a problem.
It definitely lets us know where they are in terms of willingness to make a change. Yes.
Right.
And so I think that also, we have a lot of research on like how people recover. And there is a percentage of the population that actually recovers naturally from sort of misuse or problematic use of drugs and alcohol. Those are not the people we're probably talking about here, right? The families that are in your program and the patients coming to my hospital are probably not the people that naturally recover from problematic drug and alcohol use, right? Because if their family's concerned and really struggling, then probably they would have given it up already if they could on their own without any intervention. So there are certainly those people that sort of come through and can do that. But I think we're talking about the people that actually have severe substance use disorders and severe sort of addictive behaviors and really need a lot more intervention to be able to do that.
When you talk about the integrated program, that's usually who you have in the addiction part of your program. So they have a complex mental illness and they have a severe addiction. Yes.
Yeah. We certainly also see people that we might be doing some education and intervention with, where we're saying, you're here for your depression, and this is what we recommend you do in terms of not using substances. But our addiction programming is primarily targeting people that truly have both. Mm-hmm.
Right. So we had a comment here about the importance of listening to patients rather than just diagnosing and filling them with medications. And I'd like to address that. The way that patients often come into treatment, and when they're unmanageable, they get early diagnoses. Most of us who have had family members in treatment notice an entire handful, more than a person could handle when they get out, that they're taking on everything. And some of them seem to be not well adjusting to it. Talk about that. Talk about the use of medication in early treatment versus talk therapy versus spirituality. What do you guys see? What is your research showing and your experience?
Sure. Yeah, I see the comment. I mean, I'll answer a couple of those. We actually do. We have clergy at our hospital, and often patients cite that as one of the most helpful things, right? Is really talking to like a trained chaplain who understands mental health, substance use disorders, things like that. I also agree with you that the listening and the actual therapy, right, getting to know people is missing in a lot of treatment settings. So when I was talking about like assessment, a lot of that's a lot of assessment is actually just sitting with people. when people come to our hospital, sometimes they'll say, wow, in a week here, I feel like I've had more treatment and actual therapy than 30 days at another residential. So I think actually sitting with patients is something that a lot of treatment centers don't have time to do. And this is sort of a larger, sort of more like a payer issue. It's a systemic problem where, like the comment mentions groups as well. Groups work. Like the research shows us that groups do work. So there is sort of an evidence-based reason to use group therapy for teaching skills. Process groups in particular can be very helpful, but also groups are cost effective. Like, right, I mean, if we're thinking about it, groups are cost effective. So like the quality of licensure of the providers, the amount of time somebody spends with the psychiatrist, a lot of programs might have a visiting psychiatrist. So I think that's a good question to ask too when you're looking at potential programs is this a psychiatrist that's on site? Like, and how often are they on site? Are they just here one day a week or one day a month to sort of
and why medication? Is that so important? Talk about what the importance of
that. For us, the psychiatrist is the team leader, right? They are the lead of the team in terms of formulating the diagnosis and the treatment plan, right? This is a medical professional that can provide, yes, medications to treat, any psychiatric symptoms and medications for a substance use disorder, right? I mean, we can talk a little bit about pharmacotherapy for substance use disorders, but the research does support pharmacotherapy. When we combine medications with psychosocial interventions, the outcomes are better, but medications alone is not the solution. It's both. So I think having, though, truly full-time clinicians, right, that are there, that know the client or the patient, that work together as a team, it is a big part of improving the outcomes. Because I agree, most people just want to be heard. They want to feel understood. They want to feel like you're really spending time with them. If you're rushing to see them for 15 minutes, people feel that. And then they really don't feel understood. And I think also this is why people get misdiagnosed or sort of not really get a good treatment plan, because we don't know them. Mm-hmm.
Wow. That truer words were never spoken.
Yeah.
And it just breaks my heart to hear this, because I believe that most treatment centers have the best of intentions.
They do.
They don't have the wherewithal to meet the needs in that very profound way.
I think this is such a systemic issue where you have good clinicians, but they have too large of a caseload, right? Or they're not getting good enough supervision or good enough training, and they're just busy.
Right. You guys are known for your assessment, that somebody can come to your center for 10 days, 12 days, and you really figure out what it is. And that's one of the hardest things, and often not always well executed pieces of the treatment process. Can you talk about what makes your assessments so good? What are the components? What should people be looking for in an assessment and in the whole diagnostic process?
Yeah. So we do a diagnostic evaluation a couple of different ways. One is in our inpatient programs. We do diagnostic evaluations where there's a whole team involved. And then we also do what's called an outpatient assessment, which is basically an intensive 5-day outpatient assessment with sort of a similar approach and team, but people just come during the day for their appointments and sort of, stay off site. But that includes, a psychiatrist as the team lead, a psychologist to do psychological testing, a social worker to do a psychosocial evaluation. In our case, an addiction professional, like a master's level, duly licensed. So an addiction professional that's licensed in both mental health and addiction.
Mm-hmm.
And then maybe any other consultants as needed, like an eating disorder specialist, a spirituality consult. There might be somebody assessing like for problematic sexual behavior, if that's an issue, somebody assessing spirituality, somebody doing a vocational assessment. So whatever really kind of is indicated, all of those people doing an individual assessment with the patient and then coming back together to do what we call a formulation. And that diagnostic formulation is sort of everybody that's an expert in their sort of approach, putting their minds together to say, here is sort of what we think, here's our formulation, not only sort of our actual diagnoses in the DSM, but also our core issues, like how we understand this person and what we recommend, what type of treatment do they really need based on what's going on.
So there's a lot of talking and listening.
Yeah.
What kind of tech do you use? What is the role of high tech in a good modern evaluation diagnosis?
Sure. I mean, if somebody has a sleep problem, then we have, a whole sleep medicine team, and they might do a sleep study or something like that. For psychology, they're doing true psychological testing, and I'm not a psychologist, so I won't say much about all of the different evaluations that they do, but that might be personality disorder testing or autism testing, just depending on sort of what's going on. But really, the evaluation, the diagnostic assessment is not about technology. It's about face-to-face time with that person, listening to them, getting to know them, and getting collateral, right? A big part of the psychosocial is getting collateral from the family, from any outpatient providers, might be reviewing records from other hospitals or treatment centers that they've been to. We use technology to do like our outcomes measures, but the treatment part and the assessment part is face-to-face.
Right. What about brain scans?
Mm-hmm. We do MRIs, depending. One of our programs that's sort of our comprehensive assessment and stabilization program, they do a brain scan on almost everybody, but they're often seeing people. So that program is sort of for people that might have psychosis or undiagnosed mood disorders. Sometimes they're finding that actually this is a medical problem, not a psychiatric problem. So yes, they are doing those. Mm-hmm. And then we do like fMRIs for like a lot of our research and things like that. Mm-hmm. But that's really for most psychiatric and addictive disorder diagnoses, you don't need a brain scan.
Okay.
I know that there's some programs.
There are some programs that really emphasize that, and I was wondering what your perspective is.
We have lots of research. We know what the addicted brain looks like. We don't have to put everybody under a scan to be able to diagnose a substance use disorder.
Good point. Well, at this point, I'd really like to open it up. I know there are lots of people who may have questions. Let's see. If you do have a question, you can just take off your mic, start talking, or raise your hand in the, I'll put the participant list up. We would love to hear from you. Colleen.
Thanks, Colleen.
Hey, Colleen.
I just say thank you again for coming here. This is so much information. We've talked a few times, and I just keep learning more and more. And thank you for bringing this resource and all of your education and information to us. I appreciate it. I want to give time for other people, but I just wanted to say a special thank you.
Thanks, Colleen.
And thanks, Colleen, for bringing Vaughan to us. Really appreciate that.
I'm very appreciative she came. Thanks.
And I think that Carrie might want to speak, but Carrie, you are muted.
Thank you for letting me know I was muted. Couple questions. First, how did you get so dang smart and articulate and knowledgeable at such a young age? I mean, now that I have gray hair, I can say that. Like, wow, thank you so much.
Of course.
I love that you're in the field.
Thank you.
Yeah, I had a question about a couple things, two things. First, there are online programs now to support, you know, both the family, as we can see right here, and the one with use disorder.
Mhm.
Do you, and you may not be able to give recommendations, but in terms of the level of care that you're talking about and the comprehensive look and integrated, is there anything? I mean, we're in a rural area, and we have, you know, I'm taking advantage of this amazing online program here with the BALM, but my loved one is not, you know, just has a local therapist. And are there things that you can recommend in terms of an online connection to this larger body of information?
So in terms of online resources, honestly, there's a lot out there. You know, you have just sort of self-use, like smartphone apps, right, which are exploding in terms of like what's available for smartphone apps. You also have online like mutual aid support groups. So this was happening even before COVID, but it's really happening even more now with, you know, all of your traditional 12-step programs offering virtual meetings, but also programs like Smart Recovery and Refuge Recovery and LifeRing offering great online resources. Now, none of those are treatment, right? So are you asking about like treatment that's sort of remote or recovery support?
Diagnostics and treatment because of the co-occurring situation. And, you know, I mean, I don't want to get into my own
sure
stuff, but I'm just curious, you have any pointers in that direction?
You know, if you're looking, if you've exhausted your local resources in terms of, you know, locally, maybe look for like an addiction psychiatrist. So no, not one.
I'm talking rural.
Okay. Or, you know, with COVID, with telemedicine, there has been, you know, some people can do things right within the state. So I've seen some people that are able to get providers they couldn't get before because they're licensed within your state and they might be willing to see you, right, more remotely. So that's one option. You may think about going and doing like psychological testing or something like that, you know, in a nearby city, right, to get a better assessment, because that's something that can be done in a few visits, or again, getting an evaluation with an addiction psychiatrist in a nearby city in person, and then maybe they're able to make recommendations for follow-up. We are not the only ones that do a comprehensive evaluation in outpatient. There are a few other treatment centers. If you sort of like search, you know, you know, psychiatric diagnostic evaluations, you'll get some other options that come up. And then in terms of treatment and like sort of more comprehensive support other than just mutual aid, there are programs. We have one, it's a recovery management program. So it's like a combination of recovery coaching and case management. And those types of services can be offered remotely. And there's some other places that do those as well.
Okay.
So I hope that helps. Yeah.
Beautiful. Thank you. And of course, at a certain point in recovery, we have the BALM SUD program, which is the 12 principles for the individual, and having a BALM recovery life coach and taking that course has proven for many to be a very powerful adjunct to any therapeutic process. So something else to consider. Thank you. Mary Lou.
Hi, Vaughan. Nice to meet you this evening.
Hi.
Thanks for joining us, joining Bev. So you talked earlier about there were those people that that don't need to come for treatment, and they're those. I'm just wondering about, like, I'm a recovery coach and I'm working with a 67-year-old woman who has already been through a year of treatment, and then sober living for another 7 months. And this is her second or third time out again, relapsing. I'm just wondering, do you have a specific program for people like that are older, that just, haven't been able to get it?
A treatment program, or
well, I'm wondering
recommendations?
if Menninger has a treatment program, or if you have any suggestions.
I could think of a couple. I mean, we have a program called Hope, and it is for people with sort of more chronic, right? People that have maybe been to multiple treatment episodes or multiple relapses. And that program tends to maybe have that type of patient. I know there's a couple of other sort of private residential programs that specialize sort of in that age range as well. I'm trying to think, you're also sort of thinking about just resources or ideas?
Yeah, resources. I mean, she's limited financially. She has healthcare, but, we're not sure that it's going to get her an overnight stay someplace.
Sure. I also think that one of the ingredients that we often miss with people who might have multiple relapses is monitoring. We give a lot of support, we do, a lot of structure, but monitoring, the accountability of alcohol monitoring or drug monitoring, if you look at the research in like physicians' health programs, for example, when you're monitoring somebody for substance use, their success rate goes up quite a bit. So if she's never done any monitoring with, and something that we use in our recovery management program, like we use SoberLink, where we're doing 2 to 4 times a day alcohol monitoring through a breathalyzer, and that can be done from anywhere. So things like that can kind of be added that might be helpful as well.
Okay. Yeah, that hadn't occurred to me. I did, get some education on monitoring with a case management and interventionist program that I recently completed. So,
and SoberLink, and there's a couple of other like providers that do the monitoring. People can sign up for their share. Hopefully SoberLink's going to give me a little money for this, that you can sign up for their share program, where people just buy the device and then pick who they want to be monitoring them. So their recovery coach, their family can be the accountability sort of partner for their monitoring, and it's $5 a day, I believe, once you've signed up. But that's something that in our recovery management program, we use because the majority of our clients have alcohol use disorders in addition to maybe some type of other substance use disorder. And I've had a lot of individuals who had many relapses and multiple treatment episodes say the monitoring really makes a difference for them, knowing that they've got to take that breathalyzer and that somebody's going to be keeping track of that really can be helpful. It's basically like, when we know a lot about the brain and what happens with addiction and the brain, and that people sort of really lose their decision-making capacity over time, right? Their prefrontal cortex and sort of that impulse control sort of really is damaged with severe addiction. So it's a little bit like outsourcing that part of the brain, right? I have to take this breathalyzer, or I have to get that drug test, right? It helps provide that accountability.
So SoberLinks is only for alcohol, or does it have a drug component?
SoberLink is specifically in alcohol monitoring, but there's many companies out there. If you Google, recovery management or recovery monitoring, we're not the only ones that offer that type of service, where they'll do drug testing. A lot of times the programs are 6 months to a year, and they will do drug testing and things like that in addition to case management.
Very good. And I think Lori and Colleen, it would be great to have some of those programs come on, some of the monitoring programs. So Vaughan, if you wouldn't mind sharing with Colleen one or two that you feel would be great.
Yeah.
It would be really wonderful, great resource for our families. Thank you for telling us about it. Anybody else have a question? I know we're at 9. If you need to go, folks, please go. Is it okay if we stay on a few more minutes?
Sure.
So let's see if we have any more. You can just raise your hand or turn off your mic. Looks like we're winding down. Well, Vaughan, this has been amazing. You know, I think for me, one of the things we like to do in coach training, when we're sitting in coach training, you know, we talk, or in a coaching session at the end, what's your biggest takeaway? And there were so many of them tonight. I think just opening the conversation about getting rid of this, you make a mistake and you're gone attitude that so many places have. That was powerful. Love to continue that conversation, hear about how you guys are helping sober livings to move away from that perspective. And in fact, let me ask you, is there research on this yet? Are you training people, or is it just attitudinally the perspective that you are sharing at this point?
I think it's a little bit of both. You know, the research, we have research that some people are able to move into harm reduction, right? So we do know that like a moderation harm reduction approach works as a treatment approach. That's very different than saying, oh yeah, I'm just like moderating my, like, that's not what we mean when we say that. So I think sometimes there's some misconception, but sort of really truly this harm reduction approach as providers, where we are working with people where they are, we do know that that's effective. In terms of working with sober livings, I think some of it is us just, you know, that's our expectation. It's the same as our expectation of, you know, when we started, you know, back when sober livings didn't want to take people that were on, you know, medication assisted treatment. We're pushing to say, but this is what the research has worked. So why aren't you taking our patients? And then I think really as family members, you guys have a lot of influence here in terms of what you're asking for and expecting from with programs.
I need you to say that again. Did everyone hear that? It doesn't feel that way sometimes. Yeah. One of the big things that families learn in the BALM is that they truly are partners in the recovery process. And, you know, we study this idea, we talk about this idea, we send people off to the treatment center to have the conversation. I'm here as your partner. I'm going to trust your professionalism. Sometimes parents have something to add, or spouses have something to add that's valuable, and they hit a brick wall. What would you say if there's a brick wall? What would you say to the family? How do you get past that?
It's hard, right? And because there could be a lot of reasons you're hitting a brick wall, right? Are you talking with the wrong person? Are they burnt out? Are they overworked? It has nothing to do with you. You know, were they recently just bullied by a different, you know, another family member, and they're worried that you're trying to do the same thing? You know, there could be a lot of different reasons for that. I think remaining an advocate, though, is really one of the best things that you can do. Sometimes it's, you know, putting it in writing, and seeing who else you can talk to there, right? You know, getting the right ear. Mm-hmm.
Well, I really appreciate the humanity that you bring to every relationship, the relationship with the patient, the relationship with the family, the relationship with the staff. Are you sure you're not a BALMer? We may make you an honorary BALM. Thank you again so very much. We hope you'll come back and share
Yeah.
more of your wisdom with us.
Perfect. Thank you so much.
Great to have you. And I just want to say a couple of words to the group. You know, of course, tomorrow night is the beginning of the next coach training cohort. It's very exciting. We're starting with our cohort gatherings tomorrow evening. Tomorrow morning, there's 7 steps. Tomorrow evening, there's group. Then on Sunday, 7 steps. Monday, we're on Principle 8, getting support will greatly enhance your recovery. And there's group Monday night. Journaling Tuesday morning, group Tuesday afternoon, BTI orientation Tuesday night. And next Wednesday night, we will be here for another stimulating conversation with a family member or expert in the field. And we hope you'll all check your weekly call lists and make sure that you come. And remember, everybody, be a loving mirror. Thank you, Vaughan. Thank you, everyone. Bye.
Thank you.